welcome to Misplaced Neurons, a conversation series about periventricular nodular heterotopia, gray matter heterotopia, subcortical bed heterotopia, and everything in between. My name is Yolaine Dupont, and I am your host. In today's episode, I'm delighted to chat with Dr. Shaine Morris, pediatric cardiologist and medical director of cardiovascular genetics at Texas Children's Hospital. We'll discuss cardiovascular manifestations in X-linked periventricular nodular heterotopia, PVNH for short. X-linked PVNH is caused by a deficiency in the gene Filamin A. Dr. Morris, welcome.
Thank you so much for the opportunity to be here. I'm excited to talk with you today, Yolaine.
We're glad to have you with us. Thank you so much. Dr. Morris, can you tell us about your role at Texas Children's Hospital, please?
Sure. So I am a pediatric cardiologist and I direct our cardiovascular genetics program. So that's a super subspecialized program that takes care of children that have heart disease that's caused by genetic conditions. And so we provide both consultations, so helping people find a diagnosis, figure out what's going on, and we also provide longitudinal cardiovascular care. And our cardiovascular genetics team is a pretty big team. We take care of children that have inherited aortic disorders, inherited arrhythmias, inherited cardiomyopathy, inherited congenital heart disease. And within that group, and I direct that whole group, but within that group, X-linked PVNH is under the group that's we call aortopathies, or disorders that affect the aortic or arterial or vascular system. So in addition to directing that program, I see patients with inherited aortopathies, and specifically, I see most of the children at Texas Children's that have Filamin A mediated PVNH.
Thank you. So Filamin A, you've talked a little bit about it. What is Filamin A and why is it important?
Sure. So Filamin A is a protein. So it's a protein called Filamin A, and it's encoded by a gene called FLNA. And this is a really important protein that helps make up the cytoskeleton. So the cytoskeleton is sort of the structural framework of cells and allows cells to have shape, it allows cells to bend, it allows cells to have function, and it works really closely. This protein Filamin A works really closely with actin, which is another major protein within this cytoskeleton. And so if you have alterations in Filamin A, it can affect how cells function in our body.
So we know that individuals can have a gain of function in the Filamin A gene or a loss of function in the Filamin A gene. X-linked PVNH is caused by the loss of function, the deficiency. So what happens in the cardiovascular system when the body does not produce the protein properly?
Sure. Well, there's different things that can happen in the cardiovascular system. And I'll mainly talk about the loss of function, like in X-linked periventricular heterotopia. So it can affect multiple things. And usually it seems to, we don't understand all the mechanisms, but by affecting these interactions with actin, it affects a lot of the things that are normal for smooth muscle function in the body. So it can cause the vessels, the arterial or aortic vessels in the bodies to be dilated. So the biggest artery in our body is the aorta. So it can cause aortic dilation. That's what I see a lot of. It can also cause abnormal development of the valves. So your heart has 4 valves. There's 2 atrioventricular valves and 2 valves that lead out to the lungs into the body, the aortic and pulmonary valves. So it can cause thickening of those valves, and where those valves don't perfectly function, they either don't open all the way or they don't seal all the way. It can also cause something that is a combination between the heart and the lungs called pulmonary hypertension. And this is the vasculature that feeds the lungs is abnormally thickened and has abnormally high pressure. And that's sort of we share that between lung and heart, that condition. Those are the most common. There's lots of other more minor cardiovascular conditions like small holes in the heart, like patent foramen valleys, which is a normal fetal structure, can stay more often in children that have X-linked heterotopia, or a blood vessel called the patent ductus arteriosus. That's a normal fetal blood vessel. It should close in almost everyone, but many children who have PVNH, it does not close. And we think because you need normal smooth muscle function to close that after birth, and because the Filamin A is deficient, it can't close normally. So lots of children have a PDA after birth.
So can you have a Filamin A deficiency and not know it? Like, how do kids, or because you work in pediatrics, how do families come to you? What's the first trigger, I guess, for an investigation or a meeting with you?
Sure. So there's lots of ways to get into a meeting with us, and it's for sure Filamin A is missed all the time. And I think it's very underdiagnosed in the world. So, oh, sorry. Okay. So I guess people come for a variety of ways. So one way is a family history, that an adult or a sibling is diagnosed and they come to us. So we might have an older person who was diagnosed, they got genetic testing and they find this Filamin A in another family member, and they come to us to see if that is present and if there's any cardiovascular disease. So one way is family history. Another way is that someone might have a different system affected by Filamin A. So as I'm sure you've discussed on other podcasts and you're discussing here, Filamin A can certainly cause periventricular nodular heterotopia and seizures, which is a neurologic manifestation, or can cause lung disease. So I often get referrals either from neurology or pulmonary in which they found one of the classic manifestations of Filamin A and they want the heart investigated, or they're wondering if we can understand the genetic etiology of that. A third reason is that just aortic dilation is found in a child that doesn't have many other features, or might have mild pulmonary disease or mild pulmonary hypertension. And we're trying to figure out what to do about that aortic dilation. And so they can come any of the three ways, but aortic dilation doesn't have any symptoms. It doesn't cause pain. It doesn't cause any heart complaints. And so lots of people go years and have no idea that they have aortic dilation. And that's really important. You know, the aorta is this large blood vessel. It's kind of like the hose of the heart. It gives all the blood to the body. It's the largest artery in your body. And if it gets dilated over time, there's a risk it could tear. And the challenge is we have no idea it's dilated. So it's really important to monitor, and we do treatments to help prevent anything from happening.
Thank you. So you've talked about the family diagnosis, the familiar link. In my family, X-Linked PVNH was identified only after my daughter passed away from the disorder in 2009. So Ella was affected by both the cardiac component, cardiovascular component, but mostly with the lung component. And once we received her diagnosis postmortem, we were diagnosed. Both me and my mom were diagnosed afterwards. So is that something that you see a lot of? I mean, like how many patients right now are you seeing, or have you seen? Is there, you know, you said it's vastly underdiagnosed, but do we have a sense of its prevalence really?
I think it's really hard to know the prevalence. And first of all, thank you again for sharing your story. I think it's really important to learn, and I know that's hard. You know, so I don't know if we really understand the prevalence. We know it's rare, but I don't think we know that, you know, quite how rare it is. I think I'm following maybe 16 or 17 people with it right now, which is a lot. So Marfan syndrome, which is another genetically mediated aortic syndrome, I think I follow 200 or 300 patients with this. So this is sort of in that probably rare or ultra rare category. And we diagnose parents all the time. So all the time we'll diagnose a young child because they have more severe manifestations. And then we look to see if it's inherited. And sometimes it is, and we diagnose family members. Now, one thing that I don't know if everyone understands is when we say something's genetic or that it's inherited, you know, sometimes we think it has to come from a family member, but that's actually not true. Like PVNH in your family did come from a family member, but sometimes there's things called spontaneous mutations. So sometimes people say, well, I'm not going to have my child worked up for a genetic disorder because there's nothing in our family. And like there can be cases in your family where you didn't know something was in your family, or there can be cases in which there isn't anything. Yeah, like in you, and that's in the situation in which that there's a spontaneous mutation. So sort of when the embryo is created, that there's a DNA change. And sometimes that DNA change makes your skin a little different, or your eyes a little different, or your hair a little different, but sometimes it makes your filament a little different when that gets together. And that's a change that's not in mom or dad. So we see some patients have a spontaneous mutation and some patients have an inherited mutation. And that's why it's really, really important to get tested or to get evaluated or to think about genetics when you have these conditions that sort of don't fit together. People say this is rare, or I'm not understanding, because sometimes it's unrecognized that it's in the family or it's not in the family, even though it's genetic.
So you've touched about genetics, which is a topic very important to me, obviously, because not only did it explain what happened to Ella, it explained a lot of what I've been feeling all my life, right? Everything for me can be traced back to this Filamin A deficiency. And even now in adulthood, I am, you know, followed very carefully because of so many health issues brought on by the Filamin A deficiency. Is there, like, in terms of those families, so, you know, we're talking about families who have a diagnosis of a FLNA, right? They need to be followed a certain way, but, and we can talk about that in a second, but there's families who we may suspect have a Filamin A deficiency based on their brain MRI, for example, is one clue sometimes, or some of the symptoms that they're experiencing. So with your experience as, you know, in genetics, and could you tell us a little bit what to look for, or how they could go about getting the support to get tested? Because especially in the States, it may not be easy, or even around the world where X-Linked PVNH and Filamin A are not well known. What do you suggest in that case?
That's true. So, you know, it's challenging, and certainly it varies by country and by state and by health system. There's certainly if you see the finding, which is an anatomic finding of periventricular nodular heterotopia on a brain MRI, genetic testing has to be done, because a lot of times we can find the cause. And then also when we see multi-valve disease, or you see aortic dilation with pulmonary hypertension, I would definitely recommend that genetic testing being done. Now, how do we get that done? A lot of times it is trying to see a specialist, and because a lot of times a general practitioner doesn't understand how to do it. They also, you know, 10 years ago, genetic testing was exorbitantly expensive. It was really hard to get covered by insurance. It was hard to find someone who would do it. And a lot of providers haven't updated themselves in genetics in the last 10 years, people who have been in practice for a while. So I think the best key is finding someone. So either finding a geneticist, although genetic clinics often have a very long wait, or there's actually cardiology programs like ours, or pulmonary programs that specialize in genetic disorders of the lung or genetic disorders of the heart. And most of those centers now do their own genetic testing, as well as the cardiovascular or pulmonary testing. And those centers sort of either will do the testing themselves or will help you get testing. As a last ditch, there are also companies now, if you really can't find a provider to help you, there are these genetic testing commercial companies that you can approach, and they'll do telemedicine visits with providers, with their genetic providers who are more familiar with these conditions. And a lot of times, especially the pandemic has accelerated this use of telemedicine. That's another way, because these kits now are mostly like mouth swabs. You can just get a kit mailed in the sent in the mail and do a mouth swab and send it back now. So it's a lot easier than it was a few years ago.
Yeah, thankfully, right? I remember when we were testing postmortem, the lab, one of the labs in the US, there was only 2 at the time that tested, and one of them could not handle the large mutation or the large, you know, gene deficiency on our gene. So things have changed, because I know now that, as you said, it's a lot more easily accessible. But when you're talking about those kits, you're not talking about the at-home do-by-yourself kits.
Oh, yes. No. Thank you so much. I'm not. So I'm not talking about like 23andMe. Though, please, that is not the right way to get tested. That's mostly for fun. So these are commercial companies. So some companies are GeneDx or Ambry or Invitae or Fulgent. Those are some of the Color. These are some of the commercial companies. And you don't just order a kit on your own. You meet with a physician or a genetic counselor and talk to them, and they send you a specific test that might be for Filamin A or related disorders. There's another disorder called ACTA2 deficiency, which has very similar features and also affects actin. And they will test for these specific changes. And I don't know if this is too much detail for your readers, but or for your viewers, listeners. But you know, the Filamin A change can either be a single spelling change in the DNA, so which is a base pair change from DNA, like a double helix ladder. It can have just one step of the ladder can be altered in some of these variants, or like you mentioned, sometimes multiple letters or large letters, or even the whole gene, which has, you know, thousands of letters, can be deleted. And so you also have to make sure to go with a company that's doing both single point mutation evaluation and deletion duplication testing, which is standard for most of the good genetic testing companies now. But if you say, I want to look at Filamin A, we call it del-dup or deletion duplication testing, as well as sequencing, which is where they spell out the whole gene and make sure it's spelled the right way. And sometimes a spelling change in Filamin A is not important. We certainly see people who get what we call a variant of unknown significance or benign variant in Filamin A, and maybe that's you changed a letter from, you change a letter that's a silent, right? A silent letter, and it doesn't make a difference. Or in the recipe, you put, a different kind of sugar, a different brand of sugar in, and if you're thinking of it as a recipe, but sometimes it totally changes the protein function. And so you want to make sure you're doing a reliable company that does this and that are doing deletion, duplication, and sequencing for specifically Filamin A.
And if we're talking about genetics a little bit more, we've seen this in our own community that researchers will be looking for a clear cut, what we think is a Filamin A deficiency, because all the symptoms are there: the cardiovascular, the lung, disorder, the GI components, these seizures, but they can't find it. And so they've had to change the way that they look at the gene to be able to find the mutation in a different spot. Is that something that you've experienced as well?
So sure, I'm trying to think. I don't know if I've seen it specifically for Filamin A, but I know that it happens in Filamin A and can happen in other genes. So there's a few things. If you have a lot of the features of a condition like Filamin A deficiency or PVNH, and the testing is negative, there's a few possibilities of what could happen. It could be that it's the changes in a related gene that's in the same pathway. But I think what you're talking about is when it's in the intron, and hopefully I'll get nerdy for a second. So the way that, so Filamin A is a long protein and it has certain segments, and basically the gene that encodes Filamin A only has certain parts that are encoded. It's sort of like imagine Filamin A has a really long recipe, but you know that you can skip like half of it because it's not important. It doesn't really matter. It's sort of like clean your kitchen in between and wipe off the countertops, and like that doesn't really matter. So it's sort of hidden or not interpreted when you actually make the recipe. But and so those are called, there's exons, which give the actual coded DNA, and there's introns, which are sort of the background instructions, but we don't think really matter when we're testing. So most testing only test the product of exons, but occasionally if genetic changes are from a problem with introns. So maybe the coding instructions we didn't talk about said, turn off the kettle, and you left it on, and so the coding, this thing that's hidden is really, really important. And so it's rare, it's probably less than 5% that it's an intronic mutation, and that's not on most general testing. So you have to do something called whole genome sequencing, or you have to go to someone who's which genome does intron and exon, or you have to go back to the lab and say, can you test further into the introns? But that's not always done. Those can be much harder to find.
And am I correct to say that that's probably more on a research basis that it would be available, like a case that's really puzzling a researcher that has an interest in it?
Mostly, yes. There are some labs, so you can get it from something called whole genome testing, but whole genome sequencing is pretty expensive right now because it actually sequences the introns and the exons of all 30,000 genes in your body. And so when we're just looking for the intron of Filamin A, it can be quite expensive. So that is offered commercially, but not always covered by insurance, and can be hard, and is probably too much. So yes, I mean, that exact test would find it, but it's challenging. And so mostly on a research basis. Yes.
Thank you for that.
Sure.
So we're going to switch gear for a sec. So we've talked a lot about genetics and how to go about it. What about the screening? What about someone that has a confirmed Filamin A mutation or deficiency? What do you recommend if they haven't been seen by a cardiologist yet, but we know that they have a deficiency in the gene, or they're followed by a cardiologist who may not be familiar with FLNA specifically?
Sure. Yeah. And I'll just speak to the cardiovascular screening because obviously there's pulmonary and neurologic and GI screening too. So one thing that we've noticed is the most common finding for people who have PVNH is they have dilation of part of the aorta called the ascending aorta. So the aorta is sort of like a candy cane, and it starts sort of at the curve, there's the aortic valve, and it comes up and then comes down. And as it comes up, that area is called the ascending aorta. And that's the most commonly dilated. And that area is you can see by echocardiography, but you kind of have to be looking. So I'll say the vast majority of my patients their aortic dilation was not detected on their first echocardiogram. So something to think about is that, first of all, an echo needs to be done, but the cardiology practice needs to know to look at the ascending aorta, because it's an area that can easily be missed. It's not, especially in adult practices, it's not always looked at. So echocardiography can definitely pick up valve changes, can pick up aortic changes. So one of the things is for sure getting an echocardiogram, especially for children, to look for those valve and aortic changes. Now, there can also be changes of the distal aorta or the arches of the aorta that go to the brain and the arms, or even in the abdomen or pelvis. So we do recommend, at least one heart, either CT or MRI, to look at all the vessels of the neck and the arms and the abdomen and the pelvis to make sure we're not seeing aneurysms there. Now, those are not as common. And I think if you have a baseline one that's negative, that can be done every few years, and probably more commonly in older patients than young patients, but probably should be done at least once. And if you do have anything, obviously you need at least yearly follow-up and sometimes 6 months follow-up if there is a large aneurysm. Now that's imaging. So we look at imaging. And I don't know if you want me to talk about medication management a little bit here too.
Sure, if you want, if that's something that's appropriate, yes.
Sure. So, well, and I can tell, so we don't really know. There's no guidelines for Filamin A. There's been very little research published on we know that the cardiovascular manifestations, but how to manage it, there's never been a trial done. So we don't really know. So a lot of us that take care of patients with other kinds of aortic diseases, we talk a lot, and I can tell you what people do, but we really need more funding for research so we can study this to know what the right thing to do is. But we know that patients, for example, there's lots of other conditions that cause a similar picture, that cause the PDA not to close, that cause aortic dilation. And these, like some of these conditions are the ACTA2 deficiency, a condition called Marfan syndrome, a condition called Loeys-Dietz syndrome. Now those Marfan and Loeys-Dietz are caused by a totally different pathway of genes. So they're not necessarily related to Filamin A, but Marfan syndrome is common enough that we have done multiple trials in the world to see if there's medicines that help. And we know that 2 medicines help in Marfan syndrome. One is called beta blocker. It's a blood pressure and heart rate medicine that kind of lowers your response to adrenaline, and it can lower your heart rate, can lower your blood pressure, and is very safe. And there's a group of medicines called angiotensin receptor blockers. And these medicines sort of trick your kidneys into lowering your blood pressure intrinsically through this renal hormone route. And we know that in Marfan syndrome, both of those meds, especially when used together, slow the rate of aortic dilation. Nothing reverses aortic dilation, but they slow the rate of aortic dilation because your aorta gets bigger every year. So some of us have tried those medicines in Filamin A and said, okay, do we think they're safe? And do we think they help? And the real way to know is to do a trial, which we haven't done yet. But I have tried those in my patients that have moderate to severe dilation, and anecdotally, most of them have decreased their aortic slowing. So I'm optimistic that those meds will help, and most people I know do use those medications, but it's something we need to know a little more about. Now, one caveat, that being said, the angiotensin receptor blockers, the ARBs, common ones are losartan or irbesartan. Those are processed through the kidney. So children and adults that have had a lung transplant and are on transplant medications, those transplant meds can be quite hard on the kidney. So we have to be really careful using ARBs in people who have any kind of kidney dysfunction, which is common in the transplant community. So sometimes my kids that have had a lung transplant with Filamin A, we have to stop their ARBs periodically as if their kidneys get a little sick, if they're having, something going on with their transplant medications.
Thank you. So as children grow into adults, are there any differences? I know you work on the pediatrics, but you're also collaborating with adult teams. So to your knowledge, are there, and is it completely a separate conversation that we need to have in terms of managing adults, or those are growing to be adults?
I don't know if it's a separate conversation, but I mean, I think the thing is, other medical conditions come into the fray as an adult. So you have to start having added conversations. So in children, we can talk about the lungs or the heart or the brain. And I think as you get older, you have to think about things like having children, and then lifestyles, smoking or not being as healthy. And those can all affect your cardiovascular condition. So it's bringing those conversations all together and thinking in the adult world, what is happening, your aorta grows your entire life. It grows fastest during puberty, but your whole life. So that's a continuous conversation. But then you have all these other factors that come in: high blood pressure, obesity, any other, cancer treatment, pregnancy, that can then affect. So it's more in the adult world of having, how do all these influences on your cardiovascular health have a role, and where does Filamin A lie in that, and how does that balance how we can take care of you? And one thing I didn't mention, and we didn't talk about treatment, but ultimately, if the aorta gets too big, our goal is to slow the rate of aorta growth with medications. But ultimately, if the aorta does get too big, we know that doing surgery or replacing the aorta can prevent most aortic dissections, a tear, which is what we call a tear of the aorta. And so some people, the aorta do get large enough that we would do aortic surgery to replace. And that's very rare in children. I'm trying to think I think 2 of my patients have had an aortic replacement, but it was the same time as a lung transplant. And their aorta was pretty big and they were already getting their lungs replaced, and you're in the same space. So they did a aortic, but that certainly becomes a more common conversation for an adult.
So as an adult, like me, for example, that's an ongoing conversation I need to keep open with my team, right?
Yes, that's right. Like at what point of dilation in the aorta would they consider an aortic replacement?
And as you were saying right now, I don't believe that we have formal guidelines for any of that, right?
No.
So there's been a number of articles, scientific articles that have been published, some more recent as well, including some from your team. But I guess it's our job now to raise funds to be able to help you as, an expert and researcher, try to get these answers so that our kids can grow older and healthy and our adults can stay healthy as much as possible.
Exactly. It's a balance because, heart surgery, I mean, in most of big institutions' hands, like our hands, is very safe, but there's still complications that go, and about 1% can have 1 in 100 can have a major complication. So we don't want to be doing heart surgery if we don't need to. And if someone has a 1 in 100 chance of dissecting and having a lethal event, fine, we should do surgery. But if it's 1 in 1,000 or 1 in 10,000, there's no point in doing surgery. And finding that balance of where we know that in Marfan syndrome, and that's looking at the diameter, how exactly big is the aorta? That's one of the best predictors. But in a lot of other conditions, and I think Filamin A, I don't know if size exactly is our best predictor. Can we figure out how tense the aorta is, how strong the aorta is? Some people get aortas of 7 centimeters and don't tear. And if we can let an aorta go to 7 centimeters and not tear, like, let's do it. Let's not do surgery. But who are those? That's what we don't understand. Who are those people that have sort of stronger vessels or weaker vessels or more fragile vessels? Is it males versus females? Is it certain mutations? And really getting that risk stratification. So we're only doing what we need to do to the people we need to do it to in terms of surgery is what we really need to figure out. And all the smooth muscle aortic disorders, we don't have a great handle on that yet.
So that brings me to my next question, which is research and registries, right? Which is something that you're very passionate about. And thankfully, we are very, very grateful for you for that. And all the other researchers who are interested in this and can move science forward on our behalf. Can you tell us a little bit more about what you're doing?
Sure. So, so I'm an outcomes researcher. And so that's sort of using data to figure out how to predict outcomes or risk stratify, but you really, really need lots of cases. So if I see 3 patients and one's 10 and one's 12 and one's 20, and they have a dilated aorta and they all do great, I can't really deduce anything from that. I really can't learn anything. And Filamin A is so rare that almost no single center can say, this is what you should do. We really need collaborative work. Even the big centers, I think the biggest centers in the country right now in the US are probably Boston and our center, but even our numbers, we can't have enough to really understand what to do. So we need these collaborative efforts. So as far as I know, there's 2 big, on the cardiovascular front, there's 2 big collaborative efforts going on. So one is called MAC. It's the Montalcino Aortic Consortium. It's run by Diana Milowicz out of University of Texas at Houston, which is a collaborative of mine. She's right down the street here in Houston, but she runs, I think there are over 60 centers across the world are part of it. And that registry is really focused on getting rare genetic disorders together and collecting information about the specific genetic mutation, about what systems it affects, what family members are affected, to help come up with guidance of what we should do. Now that registry, a lot more of the centers are adult, and it doesn't really have a lot of longitudinal work, but it sort of is like what systems are affected, what are the mutations we need to worry about. And it's a phenomenal registry, and we contribute all of our patients to that registry. So that's called MAC. And then we have just started up a registry called Clarity. It's Collaborative for Longitudinal Aortic Research in the Young. And we've noticed that a lot of these registries don't have as many children involved, and they don't have as much imaging involved, which I think is really the key to understanding. If we can predict the rate of growth in different children, we can help understand it. So this Clarity, we're collaborating with MAC, but we now have 30 centers in the US, and we're working with all the major centers in Canada to work with them as well. I just had a meeting with them last week. And on getting, and the goal would be all these centers. Some centers have 1 or 2 patients. Some centers have more like ours, of getting them all in this registry and sort of saying, okay, now we have 200 patients. Now we can really better understand what to do. And then those patients, we can also approach them if we do trials, et cetera. Now, how do you get involved in those registries? So there's multiple ways. So for MAC, a lot of sites across the world are enrolling sites for MAC. So MAC is based for Canadians. MAC is funded by the Genetic Aortic Disorder Association of Canada, GADA. And so you can always call up GADA, and GADA can tell you your local site for MAC if you're in Canada. For the US, lots of the major hospitals are enrolling sites for MAC, or you can always enroll directly with my institution, which is Texas Children's Hospital Baylor, or the University of Texas Health Science Center. You can do a remote, you can call, we can set up a Zoom, and you can remotely enroll. You don't have to come in person, and then we basically ask for access to your records. And occasionally we do need proof of genetic testing to be in MAC, so that would need to be sent to us too. Now for Clarity is just getting started up. So there's 2 ways. Basically, most of the centers are not doing direct enrollment. They're doing they're sort of enrolling all their past cases de-identified. So they'll send us information about those cases, but with no identifying information for privacy, because a lot of the kids we've lost, we don't have all the information. And if we only enroll current patients, we're going to miss a lot of important information. But then patients can also enroll directly with full information. And some sites have that opportunity, and you can always call our site. And so if you call our site, we'll get your name and medical records and enroll directly. So, and I will, as we have sites that are directly enrolling, I can let you know too. But right now for direct enrollment, you would call our site. You're welcome to share my email. We can put it at the bottom of the podcast or at the end. And then other sites like Canada will be directly enrolling eventually too.
So correct me if I'm wrong, because some centers are enrolling patients anonymously or de-identified, it's possible then that someone like me could already be part of the system with information shared if my center where I go to has decided to share information.
That's possible. That is possible. And so we have a check for that to try to make sure that doesn't happen. And as we get direct enrollments with the permission of the patient, we let their main center know and say, this person directly enrolled with us, as long as the patient says that's okay. And then that will be sort of de-identified and said, okay, we're going to link this with so-and-so's account, so we don't have duplicates. And we'll also look for duplicates on people that are the same age and the same sex and the same race and from the same part of the country, to make sure we don't have duplicates. But we really want to fiercely protect anyone's anonymity. So the other centers they're not allowed to give us that information unless they have a direct consent from the patient, any identifying information.
And is it fair to say that if you go to, let's say we have a patient in Finland that is interested about joining MAC or Clarity, they could go to their primary care, their cardiologist in this case, and then it's fair to say that there would be openness to that, or is
it's hard to say. That actually, that's probably not the case. So, openness to sharing records, yes.
Okay.
It takes a lot for a center to get established with MAC or Clarity. They have to go to their ethics boards, and they have to have kind of a pile of agreements about security and confidentiality, things that are really important to us. And a lot of sites across the world don't have the bandwidth to take care of all these regulations to make sure. And so a lot of sites, if you say, I want to enroll at Clarity with my local doctor, that's probably not going to happen unless you're at one of these major sites. But if you say, hey, I'm going to call Dr. Morris, I'm going to enroll in Clarity, will you share my records? Yes, almost everyone is open to that. They just don't, enrollment at the site is only going to be possible at sort of major sites that have committed to this strict confidentiality, strict ethical sharing, et cetera.
Which is a very important differential, right? Because again, they may only have one patient that they've seen, and they don't have the bandwidth to be able to establish as either a Clarity or MAC collaborator, right?
That's right. But that's why it's wonderful now, especially because you can just call us and we can do almost everything remotely. We just need access to records and a short interview with you, or sometimes not even an interview, just a survey. And then we can have you, and then patients are really contributing to the science of going forward, because the main thing is the images and the story of what has happened. So we can, and the genetic change, so we can help kind of help past cases, help us predict what's happening with future cases.
And all of that can be done remotely, like
Yes.
digitally, really.
Absolutely. Absolutely.
Great. That's fantastic. So we'll be sure to put that information on with the podcast, either on the podcast or as a link. When it comes to so we have a registry for a PVNH Support and Awareness. And we know right now that about, I'd say roughly 30% of our families who have enrolled in the registry have a Filamin A deficiency confirmed. And so these would be the people, the individuals that could easily reach out to enroll with your center, for example,
Absolutely.
for either one, possibly,
Yep,
right?
Absolutely. And we can, like, if you enroll with us, we can enroll in both. So if you called us, and Nadia runs our Clarity and Taylor Beecroft runs our MAC collaboration, but if you called, we could just get a patient enrolled in both simultaneously. And they don't conflict because we partner up and we're trying to just get the most information, and we're ultra sharing. So.
And it doesn't matter if they're a parent of a child
That's
or
right.
they're an adult.
That's exactly right.
So one important question for you, because I don't know if that plays into to what you're doing with the registries, but some of our families have adopted children who have a Filamin A deficiency. So is that something that would prevent them from being able to join the registry because they may not have all the medical history, but they may have a genetic testing?
No, as long as they have genetic testing, or, we can in some cases offer the genetic testing, though that doesn't inhibit them at all. I mean, every piece of information we can learn from, and even if we just have a current echo or a current MRI or CT, that can help us a lot. And so we don't always need the history. I mean, obviously more history is better, but we just need any information we can get, because a lot of it is, which girl, obviously we know that girls have often have the more sort of severe presentation, because the boys that have the severe presentation didn't survive. So we know that there's definitely sex differences being an X-linked disorder, but just understanding even just the demographic characteristics, the treatment characteristics, any information we can get is helpful.
And you just touched about on the differences between boys and girls. We do have in our community not only young males, but also adult males who have a Filamin A deficiency confirmed. So these would be, again, valuable information to gather as part of the registries, correct?
Definitely, because that's much less well understood. We think the male mutations are very mild mutations, that when a female who has a healthy Filamin A gene and then has this altered Filamin A gene, that healthy Filamin A gene protects them enough so they don't have the manifestations. But a male who only has one X chromosome has the altered Filamin A, then they have features. And so in general, it's a more mild mutation, but we just don't understand those mutations as much and those effects. It can certainly affect the heart, but having more of those would be hugely helpful.
We've got our marching orders for research then.
That's right.
Thank you so much, Dr. Morris, for sharing your knowledge and expertise with us. Is there something that I didn't ask you about that you'd like to add, or how would you like to close this today?
Well, I would just say, I work with several rare disease communities, and I'm always blown away about the advocacy and parent advocacy like yours. And I would just say, if you're taking care of a family member or you're affected by one of these rare diseases, keep advocating, keep fighting. It's really important. Some physicians, were raised to sort of want to know everything and think you know everything. And that's never the case in rare disease, right? Parents, families know the most. And so keep teaching your clinicians, keep asking the right questions, keep pushing. And I know it's hard, and sometimes it's, you feel like you're not getting anywhere, but that's how you make movement. I mean, you having this organization, we've learned so much about Filamin A in the last 10 years. And I would just encourage it. I think most people viewing this are probably involved in the rare disease community, and just keep advocating, keeping out there, keep asking the hard questions. And I think that will push us to have answers.
Thank you so much. It's been my pleasure to host Misplaced Neurons today with Dr. Shaine Morris. Until next time, I send you ladybug hugs and butterfly kisses. Thank you.